Okay, I just saw Trevor join. So I think we've got, oh, and here comes Kate and Dee. I think we've got a good critical mass to get started, pretty close to on time. Hi, everyone. Happy spring. Nice to see you again, and hopefully be out on the other side of any, snow interruptions or challenges like that. It feels like it's been, we're in a whole new season than last time that we got together. Looking forward to a conversation today, a lot of focus on data. So Katie is going to be taking on a lot of the presentation, and you'll, for a change, get to hear something other than me talking for most of this meeting. But we did have a couple of sort of legislative items to start off with. Maybe I'll kick off, it's not on the agenda, but with the question that you posed, Katie, around sort of the office wage and on bills and how we think about that. I will say, I think I use a process and sort of rubric that is pretty similar to the considerations that we used when we were talking about policy ideas back in the fall and coming into the year. So starting with alignment with the different areas in the statute governing the office, of course. So think about all the elements with a focus on affordability, but also think about efficiency, quality, access as well. That universe is still a lot of bills. I think, a lot of what comes through HCIFS and to some extent HHS has interaction with the scope that we have in our statute for the office. So I also think about a couple other considerations when I'm making a decision about testifying. The first I'd say would be magnitude of the impact. I think there's a lot of bills that come up that I kind of see as small tweaks that maybe aren't going to have a huge, significant sort of statewide impact. I'd put a lot of the coverage mandates in that category. That's something where I know we always see a lot of bills, and there's many that might have a small premium impact. So yes, there's an affordability consideration there, but we don't feel the need to weigh in on each and every one of those. But one like the GLP mandate bill, we looked at that, and that had such a significant premium impact that we felt like it was worth kind of stepping in and weighing in there. So that's one piece. And then the other that I consider is really kind of what can we add to the conversation. I think that there's, plenty of bills where we could weigh in on one side or another, but would really be repeating what others are saying, and it might not add a lot to the conversation. So I try to think about where we have particular expertise, whether that's because we've been looking into an issue ourselves or we've had opportunities to engage with other states and, have a good finger on the pulse of what's happening in other states, to some extent, just my history and experience in the state and at the federal level. And then thinking about where other agencies fall. I will sometimes look at a bill and think there's some alignment here, but the Bureau is so much more in depth on an insurance issue than I'm going to be that I don't think that there's much that I can say that would add or go beyond their testimony. So that's kind of the process that I go through to think about it. Obviously, it's hard to do that in the scientific way. A lot of it is subjective, and we're always trying to respond to changes and new information about the substance of bills. But I'm kind of happy to share that, I guess, view into my thinking and how I make decisions. Is that helpful? Does that answer your question?
I think it does. I think the positions that you've taken have been surprising at times, which is why maybe not the formal position, but the framing of things like 340B comes to mind. And so I was just trying to get an understanding. I mean, maybe for another meeting, but really understanding where you're getting your information and making sure that as a representative of an office that has a specific mandate, that you are that you're supplied with information from all perspectives related to legislation.
Yeah, briefly on that, I can say, I don't weigh in or don't generally submit testimony or give testimony if I don't feel like I have a strong understanding of the issue at hand. We take quite a lot of time sort of seeking out resources and doing our own research, rather, I think, than, intaking or, hearing something from someone and saying, okay, great, we'll turn around and deliver that. So I'm always happy. I mean, if there's an issue that folks want to bring up either in this forum and kind of discuss as a group, or reach out to us and flag that something is coming up and want to talk about it, I'm happy to do that. But in terms of the question of kind of where our information is coming from, I would say a lot of that is our own research, both into sort of academic sources, but the experiences of other states as well.
Thank you.
Yeah, absolutely. There's not other questions on that front. I'll just jump into the first slide that we had in the deck, which was a quick update on the bill that we discussed during our last meeting. The bill is still with the revisor's office. I know we're one of a handful of folks who are still waiting on printing and coming down to the wire here, but we hope to have that sometime very soon. It's gone through a round of edits, so could be any time now that that's sort of out in the world and printed. We did make a few changes since our last conversation, so I wanted to run through those. The first in particular influenced by the conversation with this group and also some conversations with other kind of provider organizations and folks in this space with concerns about the threshold for comprehensive review and that may be too low and may capture too many transactions and kind of present too much administrative burden, both for providers subject to the requirements, but potentially for the office and for the department as well. So we substantially increased that threshold. It would only be very large transactions that would be subject to that automatically, and then did leave some discretion to identify based on sort of the merits and considerations of an individual transaction and its impact, ability to perform comprehensive review. We did also add an assessment to the bill. We had some conversations with the department about what staffing needs could be for a proposal like this. And I think there was a concern that financing structure that's totally dependent on applications could be very uneven across the years. There may be times when there's no comprehensive review for a whole year. And that could be a challenge for bringing on potentially an additional staff member to help support the additional volume that we'd expect to see from this process over and above the existing CON volume. So we added an assessment of it's 1/5000th of 1% of earned premiums from health insurance carriers. I had to check myself on that language because it's not familiar to use, but really just looking at what the staffing needs would be and finding a number that would meet that. It's under $100,000 across the board. For most folks, it would be sort of $10,000 to $20,000 per year. And it came at that from the mindset and perspective that I think in the past, carriers have advocated for oversight here. And I would argue that fully insured carriers, benefit from a stable system, a stable and competitive system. So it feels worth saying, like, have some skin in the game and sort of, support a program like this. And just briefly on that, there's some more specific language, but it would just be limited to fully insured companies offering fully insured products and stop loss in the health space. So it wouldn't sort of be passed through to employers. It is focused just on insurers themselves. And then finally, we added an effective date, which was something we've been talking about and just hadn't put into the draft that we shared with the group of the 1st of January 2026. And talked a little bit about considerations I think we'd want to work if this bill were to pass with DLC and that they would likely do some guidance around how to manage kind of the changeover, because I do think that that's could be complicated and thinking about, what does it mean for a transaction towards the end of the year to make sure that there's not duplication of processes. Like I said, we're really committed to the concept that folks aren't going to need to go through a CON in addition to a material change transaction process. And it seemed like rulemaking or guidance would be the best way to kind of navigate a complicated question like that. Pause there, Jeff. I saw your hand up first and then happy to go to Katie.
Thanks, Meg. These two changes at the beginning, raise a bit of a worry for me, right? So the second point, is going to add a assessment or a tax to, health insurance stop loss carriers. And, presumably that's going to, staff a group within, the Division of Licensing and Certification, right? So to your point, right, they may have nothing to do for a year. So do they then turn around and use the vagueness of the first point, which says, having a material impact on competition, cost, quality, access, or equity, so if they've been had nothing to do for 6 months, does the bar of what's considered material end up going down? Because, here we are taking, money, from the insurers, which is going to be paid by premiums, right? And staffing a group that may be looking for things to do or pressured into looking for things to do. So I worry that these are going to create too much vagueness on what's going to fall within the purview.
Yeah, I can speak to that in a couple ways. I think first, just to clarify, because I'm sensitive to the point about sort of an assessment on carriers being passed through to consumers. This is so small that I don't think there's any argument that it would have any kind of impact at all on premiums or impact. It is really the equivalent of maybe a merit increase for a single employee in a year. Very, very small. That being said, I should clarify as well, when I talk about not necessarily having a transaction to review in a year, I'm talking about the comprehensive review process, where given our size and given the bar that we've set for that, there may not be one in a year. I think we, looking at a similar program in Oregon, estimated likely 1 to 2, but again, that could be variable. But that is separate from the process of submitting these transactions for the initial review. And because the statute is broad in that regard, and we would expect many more transactions to be subject to just that sort of notice requirement. That's really the main need for the position, because there are just processes around getting those posted, having them move through the process, and have response letters generated in appropriate time. That would be the main focus of that additional position, because again, it is more administrative work than they do right now. But the comprehensive review process would be performed largely, a good amount of that report process would be through our office, and likely would need to bring on contractors to do that. So that's not something where I think we're going to have a state employee sitting there with nothing to do. I think we all have plenty of work to do within the office, and have structured this in a way that's a bit able to sort of flex up and flex down as needed for that element of the review. But there is just essentially more kind of paperwork and processes to manage under this program versus existing CON, which is why I think DLC had indicated they probably need to add a position just to kind of manage those processes. Hoping that answers your question. Katie, I know you had a question as well, so happy to again.
Yeah, thank you. Well, first I want to thank you for the first bullet, which I think we had raised concerns related to that. So I appreciate the threshold change. The question is, as I recall, the previous draft replaced the CON statute with this new process. And the question is how this now interacts with the current CON statute for those projects that meet current CON threshold, but are under 100 million.
Yep, that's a good question. And it would only replace CON for the mergers, transfers of ownership, acquisition. So things like introduction of new services, those all remain in existing CON and would be subject to the same thresholds that already exist today. This would raise the bar for, I guess, required review of transactions that involve mergers and acquisitions. But in the language around comprehensive review, it does retain, the ability to assess material impact and make determinations of whether a transaction should be subject to the comprehensive review based on that. So I guess it's not a blanket, all of those transactions would or would not be subject to this. It would be, more of a discretionary decision based on the conditions and the situation of the individual transaction.
So, okay, so aside from the discretionary component, a $20 million transaction, if we're building a new $20 million facility, it will still be subject to the current CON statute. And likely would not be subject to this based on your discretion, I assume?
Not based on our discretion, because the building of a new facility wouldn't fall into the material change transaction process.
So you are raising the threshold for any CON to $100 million?
No, I think maybe I'm not answering your question clearly. I was saying the example that you gave of building a new building.
Yeah.
at one of your
Currently-
facilities would stay within CON. So I was just
Okay.
clarifying, that wouldn't be at our discretion, that would be within CON because it's not one of the changes that is defined as a material change transaction.
Okay, so I guess, all right, that's helpful. I think we'll just have to see the language. I think you had said you were going to send the revised language out to this group, and it would be super helpful if you could do that even before it's printed. Whatever, wait, yeah,
We will try. It's honestly just, it's mostly difficult because I know you know well the revising process and how difficult it is to sort of like create a clean copy, but we'll do our best. And like I said, we do hope to have that printed soon.
that would be really helpful. Thank you.
Any other questions on this? Happy to send an update too. We can absolutely put it on our list to kind of flag it for folks when it is printed. So, you know, hopefully things will move fast unless anything else changes with the legislature in their process. Okay, great. Well, then I think I'm gonna kick off, aren't I? I was all ready to just hand it off to Katie. But wanted to say we did want to give just an update on analytics planning and really focus on a couple of different work streams, I would say. So the first of those is an update on our health expenditures dashboards work. So this really ties into the set of dashboards that we published back towards the end of the summer, early fall of last year, that were focused just on hospital payments and utilization at kind of an aggregate statewide level. We're now working with MHDO on a couple of additional dashboards that use that same methodology. So these aren't really something new. They're more of a deep dive into that same methodology and an expansion of it. So one of those is adding professional services payment and utilization. The previous dashboards, as I said, were just hospital focused, and we want to broaden that to take a look at other sites of care. Likely won't be every single provider in the state, but most of those with kind of large volume or significant. So think about primary care practices, health centers, ambulatory surgical centers, and some specialist practices as well. And Katie will do more of a deep dive. I'm already getting too in the weeds. But then also think about facility level payment and utilization dashboards. So looking at a hospital by hospital to start level and being able to do the same breakdown of thinking about overall trends and changes in time in payments and utilization at that hospital level. So Katie will jump more into that, but then she's also going to talk a little bit about access and equity and measuring those pieces. This is much earlier work. We are still in kind of the brainstorming phase. So the way that we talked about this is we wanted to come to all of you with sort of like everything that Katie has found and some of her reflections on ways to manage, to measure access and equity so that we can start paring that down and thinking about kind of a framework to select a set of measures that we can hopefully report on an ongoing basis as a way to track sort of changes in access and I was going to say the equity of access, but how sort of acceptable levels of access are in the state. So with that, I think I can hand it off to Katie to take over and she'll do a more detailed kind of overview of each of those components.
Absolutely. Thank you, Meg. So as Meg mentioned, first I'll be chatting about some of the work that we are doing with MHDO. First, I'll overview we have two sets of dashboards coming out, as Meg said, using the same methodology as we used in the fall, but doing a little bit of a deeper dive. So the first set of dashboards will be hospital level or facility level, but looking specifically at hospitals, looking at payment and utilization across Maine. And the purpose of these was really to be able to identify and describe variation in payments and utilization for hospitals and also for select services provided at those facilities. The metrics we're using are familiar to you all based on our last set of dashboards. So we'll be looking at payments, including total payments, cost sharing payments, and payments per unit at some of the larger aggregations. So inpatient, outpatient, and professional services at these hospital facilities. Then we'll also be looking at total utilization by those categories. And then specifically looking at select services at the CPT and DRG level, and looking at within those levels, total payments, cost sharing payments, and payments per unit, as well as total utilization. And we'll be working with MHDO, specifically using their all payer claims database to be able to supplement these dashboards. And then highlighting the second set of dashboards here, as Meg mentioned, these are the professional dashboards or the non-hospital payments and utilization. And it will follow a very similar outline and the exact same methodology, where we'll work with MHDO, but specifically looking at the non-hospital outpatient provider type. We'll be able to look at payments and utilization across these non-hospital outpatient provider types and look at the metrics that we described earlier, including total payments and cost sharing payments, total utilization, and then again, looking at those select services, payments, cost sharing payments, and utilization within that level of CPT or DRG or CPT code for these non-hospital sites. And again, we'll be using the all payer claims database to do this. Talking a little bit, there we go, about what, oh yeah, happy to take questions.
Yeah,
Jeff.
no, thanks. And I think, you know, probably most of us know this, but the MHDO all payer claims database is not all claims, right? There are some organizations that are self-insured, for example, who wouldn't necessarily be in there. I mean, I think it's probably a good representation, but it is not the universe.
Yes, absolutely. I think that's great context. And working with MHDO, their estimations are captured about 70% of the commercial market and 100% of Medicare and main care. But that self-insured group, we don't capture 100% of, and happy to include limitations and, you know, flags as we present the dashboards in describing that we might be missing some of the, well, we know we're missing some of the self-insured group, but can estimate what that impact may be.
Yeah, I mean, I think if we're reporting on, you know, cost per unit and things like that, it's going to be pretty accurate, right? If you got 70% of the commercial, you know, excluding the self-insured, that's going to be a solid number, right? But I think for the layperson who might see these, they should understand that it's a good represented sample, but it's not everything.
Absolutely. Great point. And happy to, as we hopefully present some of the progress on these dashboards, continue to touch base on how we talk about those limitations and share them for the layperson as you described. So looking at the tentative timeline here, we worked with MHDO starting, you know, earlier this spring to establish the scope of work. And in April, they really hit the ground running first on the hospital level analysis and shoring up the approach for those dashboards, and hoping to have those, you know, completed by late June and be able to provide progress to you all in the July meeting. And then the non-hospital provider type analysis will be expected to be ready in early September. And again, hoping to provide progress, or will provide progress to you all in the September meeting. And then, you know, our aim is to be able to present some of the findings from these dashboards at the annual public hearing, which is scheduled for late September.
Or will be scheduled. It's not actually on the calendar yet. But
Will be scheduled sometime in late December or September. I will move on from here, but if there are any questions, happy to loop back related to these dashboards and some of the work that we're doing there.
So Jeff, did you want to?
Oh, yeah.
Yeah, sorry. So Kate, is there, so is there a way that, you know, the results are getting a reasonableness test, right? So that, you know, they sort of either make sense, you know, across hospitals or specific hospitals, and you know, same with, you know, non-hospitals, right? So, you know, how do we make sure that at the end of the day, the numbers, you know, hold together, I guess, by the best way to say that.
Absolutely. I think that's a great question. And I am happy to provide some general things that we talked about with MHDO, but also happy to follow up a little bit more in the weeds about some of the quality assurance they do, which is extensive on their end. But, you know, some of the benefit of this analysis is at times it mirrors a lot of the work done on Compare Maine, which is MHDO's consumer-facing product to show prices and utilization at different providers across the state. And the goal would be able to, you know, not provide completely direct analysis, but be able to check some of the analysis or some of the results that we're getting through these dashboards with some of the information we know has been well validated on Compare Maine, and use that as a little bit of a backstop to understand if, you know, we're seeing any significant outliers or anything looks off from those general trends.
Yeah, I think that's a good way of thinking about it. There's sort of, in my mind, the validation of the data itself, which I think really lies with MHDO. And I know they have extensive processes around that Karen is better equipped to answer than we are in terms of, you know, our level of confidence in the data that we're using for these analyses. And then, you know, I would say in this particular case, in terms of the methodology for the analysis that we're doing, that, like I said, that's something that we've now kind of tested and worked on with the hospital data and presented to all of you. And I think had opportunities then to think about if there were, you know, elements that we weren't considering, or if there were refinements that we needed to make or answer questions about that. You know, I do think as we turn around and apply that to non-hospital providers, you know, it may be that with smaller amounts of data, there's a little bit more kind of uncertainty. And I think we'll have to work with MHDO around, you know, what's a reasonable bar for kind of the volume of data that we're including, for example, when we're doing these analyses with potentially smaller providers. But this is a methodology that I feel like we've been continuing to kind of iterate on with all of you and with MHDO and their technical vendor as well. But happy to bring this back. I mean, that's why I think Katie wanted to kind of flag the advisory council meetings that we have coming up. I think we can definitely plan to present this like we did with the hospital dashboards, potentially before we, you know, make them public or you know, right around that time. So there's an opportunity to make revisions certainly before we kind of promote them or share them at the public hearing. So there's an opportunity for others to put fresh eyes on them and flag if there are concerns.
So if there aren't any other questions, again, always happy to come back to this section, but I'll move on to some of our consideration for another level of analysis that we are hoping to start, which is measuring access to care. And as Meg mentioned earlier, this is really our preliminary, you know, scope of understanding what are possible data sources out there that could help us really establish a baseline and continue to track what access to healthcare is in Maine at a variety of different levels. And the other thing I want to flag is, you know, here I highlight access, and throughout the next couple of slides, I talk a lot about access, but, you know, this access planning is also coupled with an understanding and wanting to measure equity. And so a lot of these data sources that I'll discuss, one of the key metrics I was looking for was detail, so that we'd be able to measure access, but then also measure equity through understanding which, you know, consumer characteristics or, you know, payer type can help us understand, or geography can help us understand some of the equity issues as well. But as you all know more than I, you know, equity is very hard to define and measure. So happy to hear guidance or get your advice on any of these things as we move forward. It's really, as Meg said, just a preliminary scope of work for some of this planning. So first, you know, just understanding what definition and domains of measuring access to care. So in 1993, the Institute of Medicine and the U.S. Committee on Monitoring Access to Personal Healthcare Services defined healthcare access as the timely use of personal health services to achieve the best health outcomes. And this definition has been adopted and used widely by public health organizations and governmental agencies over the years. Specifically, the U.S. Agency for Research and Healthcare Research and Quality uses this definition, and, you know, a variety of states, you know, aim to measure healthcare access for a variety of reasons, but 3 that I identified in looking at other states were really to establish a baseline measurement for healthcare access, to identify barriers of obtaining services and barriers for consumers to achieve their desired healthcare outcomes, and then to be able to track access and equity over time and to get a sense of how access changes, in a landscape, and specifically how we're thinking is in the state and across the state, and what different, variables or what different characteristics contribute to access. So as I mentioned, the U.S. Agency for Healthcare Research and Quality spends a lot of time thinking about access, and they really measure access in 4 domains. First being coverage, and specifically health insurance coverage. The second being services, what services are provided and where are they provided. Timeliness, which they define as the ability to provide healthcare when the need is recognized. And then workforce, and really thinking, do we have the workforce in Maine to provide the level of access to healthcare that is desired and, of demand of the consumers. We took, again, happy to take guidance here. I'll run through some of these slides that look at these 4 domains and data sources that fit into these 4 domains, but at the end, really looking for your thoughts on, this approach or other data sources that might help support some of this analysis. So to start, again, these are the 4 domains, first coverage, services, workforce, and timeliness. And the main driving questions here, I note, for coverage, who is limited to accessing healthcare based on their lack of coverage or limited by their health insurance coverage. The next would be services, what services are available in Maine, where they're located. Workforce, is the healthcare workforce in Maine sufficient to meet the needs of consumers? And then timeliness, really thinking about, are consumers able to access the care they want when they want it? And when thinking about the data sources that might, fall into these different access domains, we really wanted to look at it with 4 different lenses. And the first would be feasibility, specifically, wanting to leverage data that exists and we have access to and have access to in a readily available way. The second would be having data that has some kind of historical nature to it. So when we establish our baseline, we can look at present day, but we can also look at, a couple years before now to get a sense of how the baseline has moved recently, and then also wanting those data sources to be able to be replicable. So if we choose certain questions, wanting to be able to measure answers or responses to those questions over years to be able to track change. Timeliness, I think, is another important, consideration for data sources. There are a lot of data sources that have significant publishing lags that make it hard to interpret present day access. And then finally, detail. And again, thinking about what detail and data sources means for equity. Can we consider some of these access questions with a lens to what groups of consumers or what types of barriers are being experienced by different groups in the state of Maine?
I can maybe speak to that one for a second, just to give you a break, just from background experience, and I'm sure folks in the group have probably encountered this. Sometimes there are good, stable sources that are timely, but especially because we have a pretty small population as a state, they're sort of only reliable if you're looking at them at the state level. So just to kind of, I guess, give an example or put some color around that consideration. It's that thinking about, is this a survey that collects enough data that we could think about breakdowns by, factors like race, ethnicity, geography, age, components like that, which again, not always possible, but something that's really helpful to think about. And I think particularly helpful to think about in a small state like ours, where that's often a challenge.
Thank you. First, diving into the first domain here and looking at different different data sources that could give us some insight into health insurance coverage across the state. I, kind of arbitrarily ranked these on the right-hand side based on those 4, lenses that we just discussed, but specifically highlighting first the U.S. Census through the American Community Survey or the Current Population Survey. Both of those surveys provide estimates of health insurance coverage across the population. and really, in good geographical detail. So being able to understand at the state, county, and even census tract level, what does health insurance coverage look like in Maine? Specifically, I think a strength of the census data is they provide 1 and 5 year estimations, and they do estimate the uninsured population. So, a big limitation of other data sources, especially thinking about claims data, is we miss out on understanding our uninsured population, if insurance claims aren't being billed. There are other data sources that I list here. I think the limitations of some of these are great data sources. I don't mean to suggest they're not by the limited stars, but specifically for what we're doing is, the lack of readily available data or the timeliness of this data, specifically, and then being able to get Maine estimates. And then finally, and then I'll go to questions for this, is that the state of Maine has information on health insurance coverage through the Bureau of Insurance or CMS public use files. These are really specific to specific markets and therefore aren't capturing data truly at the full level. I'm happy to go to the question raised.
I think it's Renee.
Oh, yes.
Hi, yeah, thanks. I'm just wondering with this analysis, is there any way to tell, there's a big difference between having comprehensive health insurance and catastrophic coverage. So is there any way to distinguish that?
Yeah, that is a great question. And one of the data sources here, the Commonwealth Fund Biannual Health Insurance Survey, does a good job at trying to measure what does it mean to have health insurance but not sufficient health insurance. So exactly that, having, exorbitant out-of-pocket costs or things that deter people from accessing care. Through the census, we would not be able to necessarily get that information, but there are other consumer surveys that do supplement that information to understand what does your deductible look like, your cost sharing structure, catastrophic, things like that.
I might just add on to that quickly, and then we can go to Katie's question, because Katie Seneschal and I were talking a little bit about how do we in thinking about this framework for measuring access, try to think about the overlap with the affordability issue, because obviously we have, a separate though interrelated requirement or charge to look at affordability. So we talked about, there are ways of trying to get at ideas like average deductible within certain types of insurance. But what I think is so difficult with that is there's really no standard metric for what is affordable coverage, either from a premium perspective or a total cost perspective. And I know and have worked with states that have gone down the path of trying to do that, and I think found it really challenging. So later on, Katie will get to some survey data, and what we talked about was really focusing on those measures where people are reporting that they did not access care or didn't use care because of affordability, rather than trying to find the metric of, when premiums hit this point of this income level, that's when they're affordable, to try to kind of navigate the difficulty of that question. But totally hear you, and we do want to make sure that that's one of kind of the frameworks or considerations for access that we're thinking about, that it's not just coverage, it's also whether cost is a barrier in access.
I was known to me.
If I could just add to that, we're seeing a growing population of people who whose out-of-pocket costs exceed their ability to pay, and therefore they are going into debt as it relates to, or not paying their bills. And we're all losing on that proposition, including the patients. I think a couple of things. The Bureau of Insurance does have information, Renee, about the high deductible plans, and they track that information. And as I recall, the Affordable Care Act actually did define affordability, and I want to say it was 7.5% of income. If I may be mistaken in that. It's been a very, very long time, but the ACA did define affordability based on the plans and the exchanges, and when different exchange plans or different tiering went into effect. So I think that would be important for us to look at as well.
Yeah, the ACA definition is specifically for affordability of premiums that they use as a threshold for determining the APTC that individuals are eligible for, but it doesn't kind of incorporate out-of-pocket costs necessarily. You know, they think about.
Well, I would just say that it did in so far as it then tiered the out-of-pocket cost component based on income level up to 400%. So it's just something for us to look at.
Absolutely. And, you know, really welcome comments as we continue to talk about this. And Kate, feel free to jump in with your question there, but just wanted to say, appreciate the discussion and taking notes and happy to include some of these thoughts. Go ahead.
Yeah. One thing I would just flag, if, you know, when discussing affordability, is that sometimes it can be also hard to capture if you're looking at specific plan, like evaluating it based off a specific plan. Because sometimes what we're finding is that family members are in different plans. Like one person has it through an employer, one person's on the marketplace, whatever. So even if a premium looks affordable based off of how much one person's paying, or a deductible, you know, the out-of-pocket max for that specific individual, when you cumulatively look at the out-of-pocket costs and premium burden for like the household as a whole, it is not affordable. So just wanted to flag that in that discussion.
Yeah, appreciate that, Katie. And I think, you know, definitely glad to take that particularly. I just kind of wanted to summarize, I think, thinking about maybe medical debt burden and uncompensated care, consideration of kind of bad debt are a couple ideas that we could think about for, again, thinking about affordability, but access in particular. I think, you know, again, the hesitation that I have, I think we'll want to, I'm thinking out loud here, is that belongs maybe more in an affordability analysis than an access analysis. You know, if folks are accessing the care despite the fact that there's a cost burden, that's an affordability burden on them, potentially more than it is access burden. So again, that's, I think, what we're trying to navigate. But I think particularly maybe from the provider perspective, if there's, and again, we're getting ahead of ourselves, I should let Katie finish, but welcome maybe at the end of the presentation, if there are other thoughts on ways of collecting or accessing data about delayed or deferred care due to cost, because I think that's kind of the sweet spot of where, again, affordability intersects with access.
Absolutely. Thank you all. And I know that Jordan and colleagues have done some work on medical debt and that the data source is available in Maine. So happy to consider including that as well. So maybe a rudimentary and very quick highlight on, you know, what census data is. It's a mailed survey, it's self-reported information, and captures a variety of information on individuals. They provide nationally representative samples that can be used at, you know, state and local levels, and they capture information on health insurance status in two questions specifically: the type of insurance or lack of that an individual has, and then if they receive tax credits or subsidies to use towards premium reduction. And again, this information captures and can be broken down by different consumer demographic characteristics, including geography, income, and things like that. And I just wanted to highlight, you know, an analysis or potential analysis that can be done. On the right here was an analysis completed by the Urban Institute. Now, I believe it was 2 years ago, but they were estimating uninsurance in Maine for 2025, and we're able to use census data, specifically American Community Survey, estimates of the uninsured, broken out by geography, educational attainment, family work status, and eligibility. And this could be, you know, a similar analysis or component of an analysis that we could include, tracking what, you know, uninsurance and insurance in specific payers looks like over time at the state and specific geography levels within Maine. So I'm happy to move on to some of our other domains, but again, you know, welcome comments throughout, and then at the end as people reflect on some of this information. So the next would be, you know, and here I really look to you all on if there's a data source that I'm somehow missing on what services are available within the state and where are they being provided. You know, it's been a little bit hard for me to find, you know, a central data source for that. I think two good sources could be MHDO's data, including their APCD. Again, to Jeff's points, that's just a segment of the population, but it does get a sense of what services are provided and where, based on where the claims are coming from. And then also hospital encounter data, and that does capture not claims, but encounters at hospitals, so you can get a sense of services that are being provided regardless of insurance status, but it does collect information on the consumers that are showing up. And then I'll also highlight a third data source that I think comes in a little bit stronger for timeliness in workforce would be HRSA, or the U.S. Health Services Research Administration. Where I think it's a little bit harder here is that if we really wanted to do a scan or baseline scan of services available in the state, I think HRSA struggles a little bit with that more, but again, looking to, guidance here. Some, as we all know, MHDO's all payer claims database includes information on payment and utilization across providers in Maine through claims. And then hospital encounter data provides information on outpatient and inpatient services encounters at Maine hospitals. So potential, analyses that we could do. To the right is an analysis, or really just a graphic provided by Maine Department of Health and Human Services in 2023, specifically looking at maternal and newborn care services across the state and where they're located. I think this is an example, but being able to track, what services are being provided, and as we hear about service closures, or even better, services are being established in places, how we can get a sense of what it looks like now in 2023, maybe what it looked like 5-10 years ago, and then track that change over time. Specifically for services, we hear a lot about, including labor and delivery, behavioral health, primary care, and then also, telehealth services. Jeff, I see your hands up.
Yeah, Katie, this is hard work, right? Because in a sense, part of what you're looking for is what's not there, right? MHDO is going to tell you what exists, but it's super hard to find, the information that's or the services that are not available. And when I look at this list, right, these are certainly ones we've heard about, right? Particularly, labor and delivery over the last, few months. But I also think about, some of the, I guess, smaller bits that, are, shouldn't get lost, that and selfishly are having a significant impact on the hospitals. So, almost all post-acute care, whether it's, home health, very uneven across the state, and certainly long-term care and skilled nursing facilities, right? These are just, continuing to get to be larger issues. And I don't have any good suggestions as to how you get at that, but I think we need to get at that. And even a smaller slice, and again, I think we've talked about this in the group before, is, a pediatric patients that are housed in the EDs around the state, right? A huge problem. Not good for the patient, not good for the caregivers, and really difficult to get at. So I commend your efforts here. I appreciate how difficult it is, but somehow we need to get a pulse on, I would say, I look at this as kind of the front end of healthcare, but we also need to look at, the back end of it, or the post-acute side, so that we're getting people, to the right places of care, and, having, patients housed in a hospital for 1,000 days because they can't find the right care outside of the hospital. That's just a terrible approach on all parts. So I keep up the good work and figure out a way to get your finger on that one.
I will say that's a good opportunity to just mention, Jeff, I know the MHDO board at their last meeting was talking about that issue, and kind of working together on data collection and reporting. So I say that specific to that question, but I think more broadly, you know, we're still early in the stages and have kind of talked with Karen Lee, and I think we'll be looking for opportunities to align, but that may be a place, you know, I wanted to flag because I know there's some overlap with the group where we wouldn't be looking to reinvent the wheel, but maybe able to kind of collaborate on those efforts, and definitely a challenging one. And I think we could use all the help that we can get. I'll have another follow-up, but Katie, happy to go to you first.
Thanks. Just quickly, I think Jeff and I were thinking alike as I put in the chat that, look, he's right. It should be all post-acute care, not just nursing homes. But I would just add that the department has data related to, they're all licensed beds. So you could look at the number of licensed beds that have been closed, and for nursing homes as well as behavioral health. That data does exist. And it's with DHHS, it's not at MHDO. And this does directly impact affordability. And I think that's the piece that I want to make sure this group recognizes, is that we do not get compensated for the patients who are stuck either in EDs or in inpatient beds. And when we don't get compensated, those costs shift onto the commercial market. And so there really is a direct correlation to the work that this entity is supposed to be working on, and those two specific areas.
Yep. Yeah, I think it's a good suggestion to add post-acute. I was realizing, looking at this list now, that maybe one worth adding is emergency and urgent care. Just thinking about services where geographic proximity and timeliness is maybe especially high priority. Again, I know this is a challenge to limit the list, but kind of wanted to mention that one for reactions and see if folks had thoughts. I don't want to also only think, I guess, about what are challenges right now or in recent times. I want to make sure we're thinking about like a baseline that could track and get ahead of future shifts and changes. And particularly, I feel like that's an area where people are rethinking what does the model look like for those kind of services. So wanted to mention that one for reactions, and then also just check and see if there are other services like that where I guess in particular, you know, folks are mindful of kind of maybe especially geographic challenges outside of kind of the southern Maine region where the population is a little bit more dispersed, a lot more dispersed.
Yeah, Meg, sorry to jump in. So when I think I've shared this before, right? When we look at, you know, our, you know, Medicare ACO data, right? You know, what we find is, and I think this is true for the, you know, 4 or 3 other ACOs in the Medicare models in the state, is that our ED usage, and some of that's going to include walk-in care, is significantly higher than what we typically see, and our primary care is significantly lower, right? So I'm not sure there's an issue with access to ED emergency care, although geographically it would be important to look at it. And you know, just anecdotally, we need more primary care. I think that's, you know, hopefully, or that's what will be revealed by this, and we can work on figuring out how to get more primary care, and frankly, you know, take the pressure off the emergency care and walk-in care locations.
That's a great point. And if I may, the next slide goes out an analysis that tried to, no, to Jeff's point, I tried to look at just that. So some researchers at USM were able to leverage MHDO's hospital encounter data to do an analysis that looked at what they defined as avoidable outpatient emergency department visits using that hospital encounter data, and then looking across the state. And, you know, my takeaway interpretation of these findings is understanding, you know, based on their definition of avoidable, you know, where are there lack of access to care outside of the ED, you know, whether it be an urgent care or primary care office, and could we, you know, do a similar analysis or try to look at the data in a similar way if, you know, if we have lack of ability to, you know, hone in specifically on if there's a primary care office, you know, in this one zip code versus being able to kind of look at ED use and how the ED is being used, across the state. And are there certain areas where we're really seeing more quote unquote avoidable visits that could be deferred to, other provider settings?
Yeah, I mean, it's a great question. And, frankly, one in our ACO that we've scratched our heads over for a while. And, in this picture of the state is, pretty interesting, right? You can certainly recognize that in some cases, right, it is, access to primary care. But I can tell you right now, in the county, Presque Isle and Caribou, that's not the issue, right? There's plenty of primary care there, but just culturally, they go to the ED, and we can't figure out. We haven't figured out how to change that, right? I mean, we've worked on it, but so some of it is access, right? Some of it is, is there primary care available? Is it available at the times they need it? Which really gets to be a complicated question. But then some of it is it's just baked into how they think about their healthcare. And so this is a pretty cool graphic. We've did something, similar, sort of looking at, where the walk-in cares were available versus ED versus primary care. So it's a challenge just statewide. So even where it looks pretty good, we're not all that good when you compare us to other states.
Yeah, absolutely. And I just want to really emphasize this analysis was from data collected in 2006. So this is definitely not reflecting, and Katie, I see you shaking your head, definitely not reflecting the current status of anything, but just an example of an analysis.
I bet it hasn't changed much.
And Katie, go ahead. I think you're muted.
Sorry, that's what I was actually going to ask, whether part of your work was going to be updating this analysis, because it would be very interesting to see if it has changed, and if so, how.
Absolutely. I mean, informed by your interest. And I would say if you're interested in this, I am definitely interested in this and happy to reach out to this research group to, get their methodology to do a similar type of analysis.
I guess I would look to some of the others on this council who are on the payer side to see if emergency department use is an issue for payers. It certainly is for our ACOs, to Jeff's point, but I'd be curious if employers are viewing this as a problem as well.
Kevin in the chat said yes, it is, and Trevor just saw you come off mute if you'd like to weigh in.
Yeah, absolutely. This is a perennial problem for purchasers. We actually have seen it get a little bit better with proliferation of some more urgent care facilities, but it's still a challenge.
Yeah, I was just thinking in talking about maybe an update to this being something that we could put on the analysis agenda. I think it could be interesting to combine this with some of what we talked about before, a heat map like this. I know you can't necessarily do pinpoints for every primary care provider, but to get at Jeff's point, sort of being able to visualize avoidable ED use, and also alongside that, look at availability of primary care practices could help to disentangle a little bit, is this a lack of access to alternative sites, or is this, potentially sort of a consumer education or kind of, cultural issue, or are there other factors that might be impacting where people are seeking care?
This would be limited to the insured though, right? Based on the data. So this figure, for example, isn't captured. There's probably a big population that's missed, right? The uninsured population.
My understanding of the hospital encounter data, because it's encounters, is it does include all consumers showing up regardless of payer type.
Okay.
I, caveat that with, I'm 100% going to double check that with MHDO after this and can, send, further information if that's not true. But my understanding is they do have the uninsured population here. So this is just encounters at the hospitals.
And does it include health insurance, like if they have insurance coverage, or like what type they have?
Yes, so it does have information on the consumer specific to, the characteristics they had when they presented, including insurance type.
That could be a really good way to track changes in coverage over time as well. I didn't know that we had this, but
Yes, specific to people who are using hospital services. So again, not necessarily the snapshot of the healthy population that's not using EDs or hospitals, but it does include payer types outside of just the insured. Or I would say people who do not have a payer for insurance.
Could I just tease out one the sort of question really for you, Jeff? You were mentioning even when there is primary care available or sort of mentioned, and I think kind of grouped together, use of ED and urgent care. And I think I typically think about it a little bit like, you know, oh, well, use of urgent care in the majority of cases, you know, is more appropriate and sort of encouraged. I just wanted to get a sense. I mean, I know that's certainly not ideal, and for people's good health, we want them to have an established source of care and be, you know, going in and having preventative screenings. But I just wanted to check and see, and it may be more, you know, maybe that's specific to thinking as an ACO as opposed to maybe broader kind of concerns, but just maybe hear a little bit more from you, because I've typically thought, you know, if you're seeing more urgent care volume, that's coming out of the ED, and again, maybe not ideal, but you know, a more desirable situation versus kind of concerns about even urgent care facilities having too high a volume to kind of manage. So just want to understand that a little better.
Yeah, I mean, a couple things there, Meg. So not all urgent cares are created equal. Some of them, you know, function off an ED model. So going to an urgent care that's an ED model is not significantly different than going to the ED. It could be, you know, physically located, more convenient, and that sort of thing. And the other thing that we worry about is that you don't want walk-in care to become primary care, right? That because you don't create that longitudinal relationship that you would if you get people into primary care. So walk-in care can be good, right? It's a, you know, generally obviously lower cost many times than the ED. But it also tends to be not as connected as it could be if, you know, a patient was going to primary care. So primary care is kind of, I would say, generally the best, you know, but there's that struggle with access, right? So, you know, and a lot of times what you do see in walk-in care is, and we looked at this a few years ago, was, you know, walk-in care was used really for things that typically wouldn't be that significant in primary care anyway, but we should still be careful about that, right? So, you know, it's predominantly things like, you know, earaches and those types of things. So, you know, walk-in care has its place, but it shouldn't replace primary care. I guess that's what I'll say.
Yeah, got it. That makes sense. And something for further consideration. You know, I think it would be more difficult to define avoidable sort of use of walk-in. And again, maybe some tricky conversations there about, you know, do you want to actually keep some simple things in urgent care to keep capacity for providers to have primary care appointments, if that makes sense. But I think that that's something, as we continue to think about the analysis, we can maybe check back in on. But that's really helpful to understand your thinking better. Renee, I saw that you had your hand up too.
Yeah, I was just going to add that I think sometimes when people go to a walk-in care or urgent care situation, they end up getting a lot more testing and imaging than maybe they need because the provider doesn't know them, versus if they were getting the same evaluation in primary care with a lot of background and history. Oftentimes you don't need to order as much as is done at an urgent care or walk-in for the same complaint.
Got it. Thank you. It's helpful.
Happy to move on if that works for everyone. So the next one of our categories, only one more after this, is workforce. And again, looking to our, you know, advisory council here for other data sources. The two I've highlighted up top, the U.S. Health Services and Research Administration, referred to as HRSA, as well as the both the U.S. and Maine labor statistics have, you know, easily trackable information in these spaces, though I know that there are prominent surveys done by the American Hospital Association, as well as different provider group surveys that help try to track workforce over time. Yep, Katie, I see your hands up.
Yeah, I was just going to say, I know the nursing data that HRSA has is very flawed. So we actually, in Maine, the Board of Licensure does its own nursing survey data that has, so they have a very strong, so that's they would be a good source for you.
Great, thank you. That is super helpful. And I have a slide that shows that HRSA nursing survey, so I will caveat that in advance. But yeah, that is a great example of looking to you all for, best Maine data, because I think, to your point, these national statistics and some of these national organizations can under-report or under-collect on Maine for some of these statistics. So specifically, I think labor statistics are great because they're super timely. They come out all the time and we can easily track things over time. They're really limited because we don't know, within specific industries, what providers are being captured and things like that. I think HRSA provides some of their own analyses. However, they kind of act as a central location for data sources, but to Katie's point, the validity of some of these data sources is not always, superb, and thinking about how we can, capture the best data to get the best sense of, workforce in Maine. So this is an example of some Maine Department of Labor data. I apologize for how small it is, but again, this, just easily trackable statistics, but the aggregate level of healthcare and social assistance is not as granular. I think that would be informative to this group. This is an example of the National Sample Survey of Registered Nurses. This again is an example analysis that we could do maybe with a higher quality survey, but looking at the age distribution of nurses and other characteristics of the workforce between 2018 and 2022 helps us just understand how that workforce is changing over time and how it is meeting the demand in Maine. Next, HRSA does provide some more in-depth analyses looking at things like supply and demand. So for example, this is analysis they completed in looking at data from 2023. This is specifically looking at the behavioral healthcare workforce across states. And again, I would look deeper into some of their analyses, but they suggest that Maine's only hitting about 50% of their adequacy for behavioral health providers. So this is an example of an analysis that we could, think about completing if there's interest among the group to get a sense of what is the supply of healthcare workforce in Maine versus the demand and, how we're meeting the demand of consumers and of the workforce. And then finally, here is another, as you all may know, HRSA does an analysis that looks at care shortage areas. One of them is primary care shortage areas. They use a variety of different data sources to highlight geographical areas that they think have a limited number of either services or providers for specific categories of care. And across Maine, we could look at utilizing similar analyses to try to get a sense of what that workforce looks like across the state.
Yeah, if we're at the end of the workforce section,
Yes.
I was just gonna double check with Katie on the concerns about the HRSA data. And sorry if I just missed you saying that. That was specific to the nursing survey. Katie may also know this better herself, but I just wanted to understand a little bit better.
I think it's this nursing.
Okay.
So I don't have the specifics. Lisa Harvey McPherson is an expert on this, but she and I were talking about it and she wanted me to make sure that I shared with you that the Board of Licensure of Nursing in Maine developed its own database because the HRSA data is flawed, seriously flawed. So I won't, and that is, I mean, we know that about nursing. It could be flawed. It's probably worth looking at in a whole variety of areas if it's flawed in nursing.
Okay, got it.
Absolutely.
That's helpful. Thanks. I just want to make sure I understood. We can definitely take a look at licensure. I'm actually remembering that at one point we started to dabble around in that data, so we can take another look and refamiliarize ourselves, maybe reach out to the folks at DPFR to collaborate if there's ways that that data could be useful.
Absolutely. And then finally, our last category would be timeliness. And I think this helps touch on some of the comments about, why are, certain groups going to the ED as opposed to going, to primary care facilities. And, timeliness in this category in general is really hinges on consumer self-report of, their behavior. One of the most widely used resources for that would be the Behavioral Risk Factor Surveillance System, or BRFIS. That data is available for Maine, and access to that data is relatively easy to get. There's also some really great local consumer surveys done across the state. Why I downgraded this 5 stars is, the reproducibility of some of those surveys is difficult. They don't, they have to be funded. They don't always happen on an annual basis, and questions change over time. So I think one of the strengths of BRFIS is that they have standardized questions that they ask year over year, and that we will be able to track how the responses to those questions have changed. And they collect all this additional information, including, insurance status and demographics and characteristics of the people that they survey. There are also some other national surveys, including HEDIS has some access and availability to care measures, as well as the MEPS survey, and I'm blanking on the actual.
Medicare expenditures panel survey?
Yes, I think it's medical.
Medical, yeah.
Medical, not specific to Medicare.
You're close. I got 3 out of 4 letters.
Thank you, Meg. Why I think I downgraded these again is they're less readily available, meaning they have fees, or access to these aren't specific to the state, things like that. But just to highlight BRFIS, because I think it's a resource we could really use. It is one of the longest, or the largest, ongoing telephone survey in the country. It captures information on Americans who are over 18, and really captures a variety of information, including health status, disease, and risk factors. But for the purposes of access and equity, it captures a good set of questions on healthcare access and coverage. And data are weighted to provide what they, say are representative samples of the state. So I think it's a great opportunity for us to be able to even see within the state variation in some of these answers. And so, for example, there's analysis done in Rhode Island where they took some BRFIS data, specifically the questions there on the left on, were there times that consumers were looking for care but couldn't get it? Do they have someone that, they consider to be a personal care doctor for them? And then over the past 12 months, did you ever delay medical care due to costs? And I think, to Renee's point earlier, answer to some of these questions helps us understand some of that, not necessarily lack of health insurance, but the affordability issues even among people who do have health insurance. And, this is just an example of, Rhode Island data, but something that we could easily reproduce for Maine and then track answers over time. Similar consumer survey in Massachusetts done, where they conduct their own health survey, but include answers and questions from BRFIS. So this one specifically was looking at, for individuals who had difficulty in accessing care, what was the reason? And I apologize for the tiny text here, but some of these reasons include cost, but beyond cost, also, were they not able to access an appointment in the time that they wanted to? Were they not able to get the provider that they were hoping to get, or the level of provider that they were hoping to see, things like that. And then finally, this is another example of a question done by Massachusetts, but also included in the BRFIS data, which is reasons why someone used an ED for non-emergency reasons. And again, I think this helps provide context to some of the behaviors we might see around the state, where there may be access to primary care services, but why someone shows up at the ED for what they are self-reporting as a non-emergent reason could really help provide, additional information related to access questions. So I'm happy to wrap up here and then, open the floor for further discussion. But next steps here would be to gain your feedback and, plenty of great feedback today, but I'm also, we just provided a lot of information. So I'm happy to, if people as they digest this information would like to follow up via email or, hop on a call for a chat, happy to do that over the next bit of time. And then we would like to establish a framework for analysis and really understand, what we can use to start benchmarking access in the state, and then eventually begin that analysis and report out to you all. And then I think the key here is continue to track the progress over time and get to a point that we can understand how trends in access have changed. Happy to open the floor to discussion, or are there any other topics that people would like to chat about?
I can jump in with just one thought on that last bullet. And first of all, thank you, Katie. Really appreciate Katie's work to do this very intensive kind of landscape review here. In terms of continuing to track progress, only because I really appreciate the feedback about things like the exercise to do the mapping of availability, which I think could be really valuable, but we might just want to think separately about what does, again, a framework for ongoing measurement to track change look like, in addition to maybe one-off work products that are helpful in capturing elements right now. I don't want to, it may be possible with Katie's expertise to kind of code analyses that could be relatively reproducible over years, but I just kind of want to be mindful of that component that taking in MHDO data and doing a whole analysis is sort of a step beyond thinking about some of these metrics that we can relatively easily, grab and incorporate and kind of report out on an annual basis. So that's something we'll give some thought to as well, but just kind of wanted to note it that we have to just think about workload involved if something's going to be annual. But I'm happy to, as we do a deeper dive, to kind of think about options for that. Steph, I see your hands up.
Yeah, no, thanks. I think the the discussion we had about availability on the previous, set of slides, carries over into timeliness to a certain extent, right? So, a patient, in an inpatient bed might not experience the lack of timeliness to be able to get into home care or to be able to get in a skilled nursing facility. But timeliness, does continue to play a role there, and a little harder to get at, in those arrangements. So I think is again, something, a difficult thing to wrap your arms around, but something to try to think about.
Absolutely.
Yeah, Katie?
It's something that occurs to me, the BRFIS data, which I agree is really the only data set that has that longitudinal perspective and reliability perspective, but it is also self-reported data. So it seems important to balance that with more potentially objective data, if that's the right word, so that you have self-report, but you also have another data source that can look at sort of the objective data related to whatever it is, the topic.
Yeah, I think that's a great point, and definitely one that we will continue to understand how we might caveat and supplement some of the self-reported data. And I think why the 4 domains of access help is that we do have within each of those domains not self-reported data that would help kind of, to Jeff's point, give us an understanding of what services are available versus how we're responding to them. But there are a couple settings that have, spent a lot of time calling up places and understanding, measuring what the wait time is at each provider. I don't think that's something we would necessarily want to jump in, but, there are ways, I think, to get at that without the self-report, but good point.
Yeah, understand there's a degree of subjectivity in those, and it's, I think about finding the balance, for me at least, because again, like when I think about affordability, yes, it may be subjective, but also to some extent, that is important. If that's somebody's experience of affordability, and again, it's sort of impacting their access, I think there's validity to that, and it can be so hard again to think about objective measures for something like affordability when there are so many intervening factors. You know, a premium looks really different in one sort of economic environment than it does in another. But I hear you, and I do think, yeah, we're certainly not thinking in this work about, you know, one or two. I think we're trying to think about a set of measures that can sort of be considered all together and maybe not be the whole picture, but where there's kind of points of comparison and a couple different lenses for looking at these issues, because we know, you know, there's not one or two that are gonna kind of get at the heart or necessarily be informative for policymakers or others in the state. Maybe briefly, I was just going to say on the question about provider availability, I know we jumped into a conversation, so kind of wanted to double check if there were other data sources that anyone had on that one. I don't know if it's easy to maybe flip back to that slide, but remembering that I think that was one where we had
This one?
I think one before, yeah.
This one here.
Yeah, health service availability analysis. I mean, I think we feel good about MHDO data, but I do think the challenge there is, you know, just access, that it can be time and labor intensive to some extent to do these analyses. So only because we started talking about other things, wanted to quickly double check if those of you in this space had any other data sources that you recommend we take a look at on this. Totally fine if not. I just want to make sure we didn't miss something. Great.
I'm happy to, on some of like the workforce data and things, I'm happy to run that by our HR team and see if they have sources that are not readily, not listed here.
Great. That would be fantastic. Yeah, absolutely.
Anything else? All right, great. Well, yeah, we'll be reporting back hopefully with some good progress on analyses, especially the new dashboards at our July meeting in the summer is the next time that we'll all be together. So wishing you all the best for a busy end of session. Oh, sorry, Katie, did you want to?
No, sorry. I just wanted to follow up on the post-acute conversation. Is that something that you will consider adding to your service list?
Yeah. Oh, absolutely. Yeah.
Okay, great. Thank you.
Absolutely. All right, thank you all so much for the time and the thoughtful feedback. Great to discuss this and look forward to seeing you next time. Have a good rest of your day.
Take care. Bye-bye. Thanks.
Bye.